Yeah, yeah. It's moving back to the first slide.
Yes, ma'am.
Yeah. We start in 2 minutes. Huh?
Yes, ma'am.
So, Kavita,
Yes, sir. Yeah, ma'am.
yeah. So,
Yes.
should we ask the questions while the presentation is going on, or
Yes,
should
yes. So she will start presenting. I suggest both of you can stop her in between if you want, or after like half the history or the whole history. That's up to you. It's
Okay, fine.
entirely like a class case
Yeah,
presentation.
that's right. That's
Yeah.
right.
And
Yeah.
after history, you can sort of
Yeah.
tell her to summarize a provisional. Then after examination, and usually how we do, but we
Yeah.
should after around 10:45 we should try to wind up. And last 3 minutes you can give you and Dr. Amay can give your feedback because the
Yeah.
next session is around 11:50.
Correct. No,
Start
we'll
in one
finish
more minute.
before that. We'll try to finish before that.
Yeah, in a few
Yeah.
minutes extra is fine, but
Yeah.
not much beyond.
Yeah. Yeah.
Okay, it's 11th, I'll start.
Yeah.
So, good morning, everyone.
Amaya is
Yes,
there,
yes,
no?
ma'am.
Sorry.
Amay is there, no? Amay, you're
Yes,
there,
ma'am.
no?
I'm there, ma'am.
Yeah, yeah.
I
I'll
can
just
see
start
him
and
on the screen.
introduce
Yeah.
you all. Then you can start. So, good morning, everyone. I welcome all of you to another session of Maharashtra Rheumatology Association, a student-teacher interface. Today, we have a postgraduate student, Dr. Nikhila from Bharati Vidyapeeth, first-year DM student, who will be presenting the case. Esteemed faculty and moderators for today's session are Dr. Jyotsna Oak from Mumbai. She has been my mentor. She's a senior rheumatologist at Gokilabai Numbani Hospital at Mumbai. And she's a very senior teacher, an excellent person, renowned rheumatologist of Mumbai. Our second teacher today is Dr. Amay Pathak. He is DRNB from Kochi in clinical immunology and rheumatology. He's presently practicing in Pune. He has a clinic in Baner. It's attached to KEM at Jupiter Hospital. So I hand over the session to both of you. Welcome, everyone. Yes. Ma'am, you can start.
Ma'am, can I start, ma'am?
Hello, am I audible? Yeah. Thank you, Kavita, for the nice introduction. Yeah, please, Dr. Nikhila, can you just start?
Yes, ma'am.
Yeah.
Good morning, everyone. I'm Dr. Nikhila Brahmani, Senior Resident in Department of Rheumatology in Bharati Vidyapeeth Medical College, Pune. Today, we'll be discussing a case of about a patient of 43-year-old age, male, working in food delivery services, hailing from Pune, with chief complaints of rash over the face for 5 months and weakness of both upper and lower limbs for 1 month, with difficulty in swallowing for 1 month. Coming to the presenting illness, he was apparently all right 5 months back, and the rash started 5 months ago. Initially, started over the face. Initially started over the face. Involving
Can you
the
tell
malar
other people
area.
to mute their...
Mr. Prasad, just mute everybody else except the speakers.
Yes.
Mr. Prasad, please mute the others.
Yes.
अभी आ रहा है आवाज.
बहुत ही आवाज.
The rash started over the face, involving malar area and forehead, followed by rash on the back, neck, upper chest, and on the hands and fingers. All lesions are progressed over the period of 1 month and have been static since then. The rash is associated with itching, and aggravation of sun exposure is present. Later, the rash he had areas of skin lightening over the rash, and the rash is not associated with any tightening of skin over the hands. It is also associated with redness and swelling around the eyes. He had complaints of weakness since 1 month in the form of difficulty in getting up from squatting position and getting up from the chair, climbing stairs and getting out of the bed, and complained of difficulty in raising arms around above the head while taking objects from over the upper shelf. No history of slippage of chapels or difficulty in gripping chapels.
இந்த
No
கிளாஸ்
history of
பண்ண நீங்க அட்டன்
difficulty
பண்ணுங்க
in
டேஸ்ட்
mixing
பிரசன்டேஷன்
food
மாதிரி
or
தான்
holding a
ஏதோ
glass.
சிஎன்எஸ் கேஸ்ன்னு நினைக்கிறேன் என்னன்னு தெரியல
No history of difficulty in mixing food or holding a glass. No history of stiffness, twitching, muscle wasting, or cramps. Weakness is associated with pain. No history of any diurnal variations, fatigability, or episodic weakness. And no history suggestive of any cranial nerve deficits or sensory involvement. And he had difficulty in swallowing since 1 month, which is more to solids than liquids, and it is not associated with any nasal regurgitation, no painful swallowing, no bouts of cough after food intake. He had history of loss of weight of around 3 to 4 kg over the past 2 to 3 months. No history of change in voice or speech difficulty, no history of dyspnea on exertion, no history of fever, no history of dark colored urine or reduced urine output, no history of joint pains, no history of bluish discoloration of fingers after cold exposure, no history of alopecia, oral ulcers, no history of dryness of eyes or mouth, no history of heartburn or water brush.
Yeah, so from this history, can you just summarize your history and come to some conclusion?
Yes, ma'am. A 43-year-old male with no old male presenting with the complaints of rash since 5 months and weakness of both proximal muscle weakness of both upper and lower limbs since 1 month.
What do you
And
think about the rash in this patient? Is it having any characteristic features of the rash?
yes, ma'am. The area of distribution of the rash and the association with itching uh, and the persistence of the rash is likely pointing towards the skin manifestations of dermatomyositis to me, ma'am.
Yeah, more than dermatomyositis, can you tell us some common conditions wherein you can get rash and muscle weakness? What about the viral fevers?
Yes, ma'am. We can see infectious causes like in viral fevers. We can
Yeah,
have infectious myopathy,
yeah,
and it can be an overlap myositis with other CTDs like SLE having rash.
yeah.
Uh,
So can it
and
be just drug-induced rash and a muscle weakness as well? Which are the drugs which can cause rash and the muscle weakness?
um,
Anything like hydrolysine, procainamide,
procainamide, yes,
yeah,
ma'am.
dapsone.
Yes, ma'am.
Yeah,
Dapsone.
yeah. Does
Yes,
he
ma'am.
have any characteristic feature like lymph nodes, or did he tell anything like swelling anywhere, submandibular or
No,
anything?
no, ma'am. No
Why do you
swelling.
ask about that?
If there's any swelling in the preauricular or submandibular region, it can be suggestive of Sjogren's, or if there is any swelling over the abdomen or any masses, lumps in the
Yeah,
body, it
yeah.
can suggest some malignancy that can be associated.
Okay. Uh, okay, go ahead.
Yes, ma'am. Coming
Yeah,
to the other history,
Just want to interrupt a bit. So, at this point of time, as ma'am rightly said, that this is a case of rash with proximal upper and lower limb weakness. So, the differentials per se would be either the inflammatory myopathies or connective tissue disorders.
yes,
So,
sir.
when we are deciphering that, I think the ones which are the CTDs which can manifest with the involvement like inflammatory myopathies? What do you feel?
Uh, yes, sir. It can be SLE, it can be systemic sclerosis, it can also have MCTD.
Okay. So, MCTD history, what all negative points you would like to ask?
MCTD, I asked about history of rash, sir. I asked about history of bluish discoloration of fingers on cold exposure,
Mhm.
suggestive of Raynaud's, and
in the
Puffy
history, just
fingers or
dryness
joint
of,
pains,
yes, and
puffy
puffy.
fingers and
puffy fingers, swelling of the swollen fingers.
right. So, what's that's about CTD. And when you talk about, say, now inflammatory myopathies, what all domains can be involved in inflammatory myopathies? Like which all organs can get involved?
Uh, Firstly, extramuscular involvement in inflammatory myositis can be skin, sir. as seen in dermatomyositis,
Right.
and in some other myositis in the form of calcinosis, and
So,
it can have
how
lung
did you
involvement
ask
in the form of
calcinosis history?
history. I have not asked it in examination. I
So,
think
can you ask anything which patient may not tell you upfront, but just will give you clues whether it's like that?
indurated skin, thick.
Face like can discharge can come out where
Whitish
essence of
discharge can
whitish
come
discharge like come from the
Yes, a
elbow
discharging
or
lesions.
the yeah
near the bony
Trunk,
body
prominences.
prominences.
and
Yeah.
also trunk.
They
Yes, sir.
can be painful also.
Yes, sir.
Yes, go
Can
ahead.
you
Which
tell
other
me any
organs?
other, sorry, can you tell me any other cause of calcinosis besides the dermatomyositis, scleroderma? Anything else can cause calcinosis? What is
Uh,
tumoral calcinosis?
tumoral calcinosis, it can be because of metastatic calcification.
Hmm. Yeah, and that can also be seen around elbows, right?
Yes, sir. Yes, ma'am.
Okay, go ahead.
Yes,
So,
ma'am.
which
Coming
other
to
organs? Yeah, just want to finish the history pertaining to this. Did you ask about any history of dry cough or breathlessness?
Yeah,
I
she
asked
said,
about breathlessness, sir.
Okay.
Dry cough, cough following intake of food, I've asked, which is negative, and breathlessness is also not there, sir.
No, not pertaining to the food per se, but a dry cough as such, intermittently. Is there
Ye-
significance of this history?
Yes, sir. Maybe it can be suggestive of underlying ILD also.
Yeah, yeah, that's also one of the important histories, just to cover up the extent or
Yes.
the domains which are related to this. Yeah,
Yes, sir.
rest of the things are fine. You can go ahead with that.
Yes, sir.
you said there is a significant history of dysphagia, right, in this patient?
Yes, ma'am. Dysphagia is there, ma'am.
Yeah, yeah. Okay. So, you're saying predominantly a muscle disorder. Can it be a neurogenic disorder? Proximal muscle, you're saying weakness is there,
Yes,
and now
ma'am.
he has got dysphagia. Can it be a progressive, any other disorder?
Usually, NMJ disorders can also have proximal muscle weakness and involvement of bulbar muscles, ma'am.
Yeah. So, whenever there is bulbar muscle involvement, you can keep your this thing little bit wider. You
Yes,
can keep
ma'am.
your differential little wider. Yeah.
Yes,
So
ma'am.
you have to also say that there is no sensory involvement, right? He is
Yes,
able
ma'am.
to.
I've mentioned, ma'am, no
Yeah.
sensory deficits, ma'am.
Yes. Okay. Fine. Go ahead.
Yes, ma'am. Coming to the other history, there's no history of similar complaints in the past, and no diabetes, not a known diabetes, hypertension, and ischemic heart diseases or thyroid disorders.
What are
And
the
personal,
muscle disorders which are seen in diabetes?
uh,
What is diabetic amyotrophy?
it it occurs as painful weakness, painful tender thigh muscles, ma'am.
Time,
Mostly
right?
vastus medialis is commonly
Yes.
involved.
And it is wasting over there.
Wasting, yes,
Yeah,
ma'am.
yeah, yeah. Okay. It suggests usually the chronicity of the disease.
Yes, ma'am.
Yeah. Okay.
So personal history takes normal mixed diet, no
And
sleep
what about the
disturbances.
thyroid disorder? Why did you ask about thyroid? Tell me about the muscle disorders which are seen in thyroid.
Thyroid can all both hypo and hyperthyroidism can present with muscle weakness, ma'am. In mixed
Correct.
muscle weakness, and hyperthyroidism can aggravate muscle weakness of any other cause also. So we need to be treating those if there's underlying thyroid abnormality, ma'am.
Yeah. Do you
They can
get
per se cause muscle.
any other disorder with thyroid? What about hypokalemic periodic paralysis? Is it commonly seen with any thyroid disorder? It can be seen with
Yes, ma'am.
hyperthyroid.
Yes, ma'am.
Hyperthyroid.
Hyperthyroidism.
What about parathyroid?
Yes, ma'am. It can cause hypocalcemia, which can
Yeah,
and calcium homeostasis disturbances. Both hypo and hyper can be causing muscle weakness, ma'am.
correct. Then both can cause proximal muscle weakness.
Yes,
It
ma'am.
can be also prolonged, right?
Yes, ma'am.
Yeah, okay. So in any muscle disorder, always ask about thyroid and check for the thyroid.
Yes, ma'am.
Yeah, okay. Can
Coming to Personal history, no sleep disturbances, no bladder disturbances, and ex-alcoholic, alcohol intake in the past, non-smoker, and denies any high-risk behavior or addictions. Ma'am, family history. Uh,
Yeah.
Family history, daughter diagnosed with vitiligo at the age of 4 years, and no history of malignancies in the family, no other significant family history, ma'am. And treatment history, he has consulted a skin specialist 1 month after rash onset, and he was prescribed topical steroids and a short course of oral steroids for the same. And rash improved marginally, but weakness appeared while he is on medications, ma'am.
Yeah.
So coming to the summaries, a 43-year-old male, no known comorbidities, presented with erythematous photosensitive rash, erythematous photosensitive pruritic rash over the face, neck, upper back, and upper chest, and subacute symmetrical progressive proximal muscle weakness involving both upper and lower limbs, and neck muscle weakness with dysphagia since 1 month. And my differentials are most probably it's idiopathic inflammatory myositis, likely dermatomyositis. And I'm also keeping in mind the possibility of overlap myositis, which we can rule out after examination.
If this patient did not have any history of rash, what other differential you would have kept in mind?
If
Because
he
he
does
doesn't have,
didn't have
yeah,
rash.
yes, because he doesn't have Raynaud's, he has only rash. And suppose the
Yes,
rash was not there, if you would have said anything else. It can be, of course, a polymyositis.
yes, ma'am.
Yeah,
Inflammatory myositis, and it
yeah,
can be no history of fever, so I won't be thinking
yeah.
about
Just
infective causes.
going little bit, away from this. What are the hereditary muscle disorders which can be seen at this age group?
Facioscapulohumeral dystrophy,
Very good.
limb girdle.
Slim
Uh,
girdle and facioscapulohumeral. Ocular and can come also at this age group. Yes. And
yes, ma'am.
what about the glycogen storage diseases? Can they be seen?
Yes, ma'am. Glycogen storage disorders can also be seen.
Like
Maltese
McArdle's.
myocardials. Yes, ma'am.
Yeah.
Maltese
Yeah. Correct.
deficiency.
Okay.
Yes, ma'am.
Right. And what about mitochondrial myopathies?
Yes, ma'am. Mitochondrial myopathies can also be possible, usually, but they will have an family history. They can have a family
Correct. So
history
that's why the
also.
family history is very important in all these disorders. And maybe later on by investigations, we'll be able to uh, make out, whether it's a mitochondrial myopathy like MELAS and MERVs, and you can always check whether the patient has got any lactic acidosis or red ragged fibers on the
Yes,
biopsy.
ma'am.
Yeah, because we have come across 2 or 3 such patients who were put as a diagnosis of myositis, but we could come to another conclusion in them. That's why I'm trying to share it. Okay?
Yes, yes,
Yeah,
ma'am.
yeah, yeah. Please go ahead.
Yes, ma'am. Coming to examination, his height and weight are amounting to a BMI of 24.4.
Hmm.
Vitals is febrile, pulse rate is 84, regular and having normal volume. BP is 160 by 70. Saturations are 98% with room air, and respiratory rate is 16 per minute, abdominothoracic type, and a single breath count coming above 30. No pallor icterus, cyanosis, clubbing, or lymphadenopathy, pedal edema. Skin examination showed multiple hyperpigmented macules
Yeah,
over the
sorry.
face.
Just one other thing you should see is also the throat examination.
Oral cavity, I've
Oral
mentioned it
cavity.
later, ma'am. Yes,
Yeah,
ma'am.
okay.
Yes, ma'am. So multiple hyperpigmented macules and patches over the face, and depigmented macules with erythema over the neck and anteriorly and posteriorly, and also the upper chest. Multiple deep pigmented patches with areas of follicular sparing are noted.
Yes.
Um, an erythematous rash over the knuckles is present. Erythematous thickened papules over the elbows and knees are also present, and no evidence of calcinosis.
Can you just show his hands again?
Yes, ma'am.
Yeah, yeah. So there are no other Gottman's papules or anything. This is almost like a depigmentation, right?
Yes,
Not
yes, ma'am.
hypo, it's almost depigmentation.
Yes, ma'am.
Does he have any discoid lesions in the ears or behind?
No, ma'am. No discoid, no lesions elsewhere.
Okay.
His only distribution is over the face, upper
Yeah.
neck,
Does he have any
upper back.
digital pitting, scarring, or anything?
No, ma'am. Digits and nails are also normal.
Normal. Okay. No scarring or pitting over there.
No, ma'am.
Yeah. Okay. Because this is like, a lot of depigmentation with
Yes, ma'am.
spotted hyperpigmentation type. And
Yes,
there is
ma'am.
no
It's more
thickened
with
skin
salt and
anywhere.
pepper appearance. No, no thickened skin, ma'am.
Okay.
Yes, ma'am.
Nikita, the the distribution of the rash, uh, were the ulcers present any point at the history or examination wise on the knuckles per se, or they were predominantly on the phalanges? What do you think? Or what was the involvement like?
From the history, sir.
History and examination both.
History-wise, he was telling the distribution vaguely, sir. On examination, the distribution of rash is more over on the hands. I'm saying it's more over the wrist and phalangeal and over the phalanges, sir.
Yeah. Over
And
the
some
hand you
erythema
say
is
he
also
has.
present over the knuckles.
Yeah. Uh, what about the other side of I mean, the palms, whether there is any tendinosis or anything like
No,
tendon
no,
friction rub? By looking at these hands, you should try to see all the
yes,
signs
ma'am.
like a scleroderma.
Yes, yes,
So
ma'am. It's a
friction
salt and
rubs
pepper.
also will be okay to see.
Yes, ma'am.
Yeah,
Yes, ma'am.
fine.
Can you tell me what's the distribution difference between the lupus associated rash on the hands
Yeah,
versus that in the dermatomyositis?
dermatomyositis.
Yes, sir. In lupus-associated rash, there can be rash over the dorsum of the hand, but usually the MCP joints, skin over the MCP joints will be spared.
The knuckles are spared, no?
Knuckles are spared,
It is
and
between
MCP
the
joint.
yeah. It is between
Yes,
that
ma'am.
the area you will be getting
Yes.
hyperpigmentation. Yeah.
Ye-
Also,
Okay.
what's
Yes.
the
Where else
importance
do
of?
you get? Sorry.
Yeah, ma'am. Please continue.
Yeah, sorry. Where else do you get Grotton's papules? And what is Grotton's sign?
Gotran's papules are slightly elevated, violaceous
Yeah.
pigmentation over the
Yeah, but where else do you
same
get? On the
distribution.
knuckles, everybody says no, but Grotton's papules you can get around the other joints also, like knees
Yes,
also.
ma'am. Wrist, elbows, knees.
Knees. And what is Grotton's sign?
If there is no elevation, if it's just a macule, it can be called as Gottran sign, ma'am. It can be present over the similar distribution only.
Any other things you see in the fingers in case of dermatomyositis?
Yes, ma'am. I over the around the nails, if there's any overgrowth, cuticular overgrowth, or
Right.
any periangular erythema, or
Yeah.
any telangiectasias.
Yes. Okay. There
Oh,
is no calcinosis in this patient, right?
No calcinosis, ma'am.
Okay. Was
which
he
other
exposed?
rashes you would like to examine in such cases, Dr. Nikila?
So, sorry,
On the
sir.
hands. In the hands, which other areas you would like to look and what all signs you can see in the hands pertaining to this spectrum?
Dermatomyositis, yeah.
Dermatomyositis.
I'll also like to look over the palm, sir, if there's any papule similar to Gottran's is there on the palms.
What is mechanic hands?
Yeah, make it.
Mechanic hands is thickened and roughened skin over the fingers, usually on the radial side of the index fingers, more commonly on the radial side of the index finger.
Yeah.
It
And that
What
is
can be seen
suggestive
distribution
of
in
of hand?
the
antisynthetis.
Yeah.
yeah.
Okay.
Yeah.
And on the palms, you were saying, no? What is the sign of the this quadrants on the palmar aspect?
Inverse Gottran's, sir.
Yes.
Correlation of it?
Correlation, it has an antibody, I mean, it can be correlated with the anti-MDF5, sir.
Yeah.
Good. Okay.
Yeah. Good.
Yes, ma'am.
Carry on.
Yes, ma'am.
Yeah.
So oral cavity examination is normal, and hair, male pattern baldness is present, and digits and nails are normal. No swollen and tender joints are there.
Oral cavity, anything else you would like to see? Of course, the dryness of mouth.
Yes,
Oral
ma'am. Dryness
ulcer.
of mouth,
Yeah.
any palatal ulcers if they're there.
Yeah.
And because he had dysphagia, I'll also look into other causes of dysphagia, local causes of dysphagia.
Yes.
Uh,
And of course, the
it,
tonsils and the adenoids because lymphoma is
yes,
quite associated with this thing.
okay, ma'am. Yes,
Yeah.
ma'am.
Yeah. With polymyositis. Okay.
Yes, ma'am.
Yeah.
Uh, Coming to systemic examination, CNS examination, higher mental functions are normal, cranial nerve examination is normal, and gag reflex is also present. Motor examination, his bulk is normal and there's no wasting and it is symmetrical. The bulk is symmetrical and tone is normal in all four limbs and all joints.
Sorry,
The
one more
power,
thing in general examination. Did you said about the lymphadenopathy, right?
yes, ma'am.
Yeah, and the sternal tenderness again. Okay, hepatomegaly, splenomegaly. All these
Oh,
things are for the paraneoplastic.
yes, ma'am.
Yeah.
Parabdomen, yes, ma'am.
Okay, carry on.
Yes, ma'am. And the power, coming to the power, his power, neck flexion power is 4 by 5 and shoulder 3 by 5, elbow 4 by 5 on bilaterally. Distally, wrist is 5 by 5 bilaterally, hip is 3 by 5, knee 4 by 5, and ankle 5 by 5. More pointing towards the proximal weakness that we have attributed in the history. Reflexes, superficial reflexes are present and plantar reflexes flexed. Deep tendon reflexes are normal. The sensory examination is normal and no cerebellar signs or signs of meningeal irritation. Skull and spine is normal. Other system examination, CVS, respiratory and parabdomen is also normal, ma'am. There's nothing significant in the examination.
Are there any contractures in the musculoskeletal?
No, ma'am.
Yeah. What is Emery diffuse syndrome?
Emery,
It's also hereditary myopathy.
muscular dystrophy.
Yeah, correct. And you get contractures there.
Yes, ma'am.
Yeah, yeah. Humoral or peroneal?
Oh, yes, ma'am.
Yeah, yeah. Okay, carry on.
Final diagnosis,
What's the relation
43.
with chest? You said that.
Respiratory system, I've
No,
mentioned, ma'am.
no, no,
Chest
no breath.
breathing pattern is abdominothoracic, which I've mentioned earlier.
Why is cardiovascular important in this patient?
Yes, ma'am. Because as we are thinking more towards inflammatory myopathies,
Yeah,
cardiac involvement can also be there as an extra muscular involvement in the form of myocarditis or LV diastolic failure
okay,
or any conduction abnormalities.
right.
Dr. Nikhila, can you just go back to neuro examination slide, please? Yeah, just little. Have you examined the neck power, or neck muscles, or like neck flexor weakness or anything?
Yes, sir. I've mentioned the MMT8 also, sir, in
Okay.
uh,
What's the significance of neck flexor weakness in this? So,
neck
sorry,
flexor weakness. If it's present, it is more pointing towards the severity, sir. It is more severe. The progression of the muscle weakness is severe.
yeah, I meant to say, like how good is the neck holding that needs to be assessed. What indirectly it can tell us about is the respiratory muscle weakness also, and his ability
Followed.
like bulbar involvement coexists or not.
Yes, sir.
So,
Usually, if neck muscle involvement is started, it can follow. It can
Bulbar.
be followed by bulbar and respiratory muscle weakness.
Yeah.
yeah, these
Another
are
thing, in
important.
case of Guillain-Barré also, no, you can get, suppose you want to differentiate
Okay, yes,
between
ma'am.
neurogenic weakness and
Yes,
myogenic.
ma'am. Proxim. Yes, ma'am. But the reflex examination, reflexes here are
Yeah,
normal, ma'am.
also present. Yeah, that itself differentiates between the two. Yeah.
Yes, ma'am. So, a 43-year-old male with bilateral upper and lower limb proximal symmetrical muscle weakness with skin rash and swallowing difficulty and no respiratory compromise. The final diagnosis is dermatomyositis, and assessment of the MMT8 score that was done is 59 by 80.
Hmm. Okay,
Next,
near 7. Yeah.
yes, ma'am.
Yeah. Okay. Got it. Yeah.
So, should I proceed to the investigations, ma'am?
Yeah.
Yes, ma'am. So initially, during presentation, his investigations showed uh, around normal ESR and CRP. SGOT-PT, SGOT is, sorry ma'am, I've uh, written it wrongly, 48. SGOT is 48 and SGPT is 20.
Yeah.
CPK is 358 and LDH is 360, both are elevated, and creatinine value is 0.9. And electrolytes are also within normal limits. ANA-IF pattern showed 1:160 nuclear fine speckle.
Mm.
Chest X-ray is normal, and the EMG that was done, it showed multiple spontaneous activity in right deltoid and right vastus medialis, and the motor unit potentials, polyphasic low amplitude potentials are seen in triceps, biceps, trapezius, gluteus medius, and vastus medialis, ma'am. So
So
it's
in all these
pointing towards a
cases,
myopathic,
right? Yeah.
suggestive of the myopathic pattern, ma'am. Coming to the myositis panel, we have also seen that it is showing TIF1 gamma strong positivity and Rho 52 positivity, weak positivity. And the nail full capillaroscopy that was done showed reduced capillary density, giant capillaries, and ramifications and arborifications, and bushy capillary on the right side, as we can see on the right side. Because of the antibody
Stephen gamma,
positivity,
yeah. The Stephen gamma suggests that there could be possibility of
uh,
underlying malignancy.
yes, ma'am.
Yeah.
High risk of malignancy with TIF1 gamma.
Yeah.
So we've also advised the PET CT,
Yeah.
which just showed increased uptake in strap muscles and masseter, but no avid uptake of FDG, depicting any prime occult.
Okay.
So we've treated this patient with oral steroid of 1 mg per kg, ma'am, prednisolone of 1 mg per kg, and
Yeah, before
Folitrax.
coming to this, is there anything else you would have done? You have done the PET scan, right?
Yes, ma'am.
Yeah,
We've
and it didn't show
initially
any
thought,
FDG uptake in any other area.
no, ma'am,
Yeah, okay. In the masseter area, is there anything with the parotid? Nothing was there.
nothing, ma'am.
Typical.
Just the
Okay.
muscle uptake is there.
Yeah. Okay. Fine.
Yes, ma'am. So we've started him on prednisolone 1 mg per kg, and we've started methotrexate at 15 mg per weekly.
Hmm.
Uh, and he reviewed the review assessment done after about 2 weeks showed decrease in muscle enzymes CPK from 358 to 74, ma'am.
So
And
actually, I would like to ask you one question over here because you are managing the patient. Is the CPK always correlating to the muscle improvement, or and how much you know importance you will give to CPK alone?
CPK can be an early marker of the muscle myositis, ma'am,
Actually,
but it
CPK
doesn't
should not
correlate with the
be
severity.
right. It doesn't really correlate with the
Yes,
severity.
ma'am.
What you have to do is the scoring of the MM8. What you have done,
MMT8, yes,
the
ma'am.
MMT8, yeah,
Outcome,
and the
yes, ma'am.
outcome like daily, course, whatever he's.
Yes, ma'am. HAT score and patient global assessment, physician
Yeah.
global
You,
assessment,
you also
MMT8.
said that he has got muscle dysphagia, right?
Yes, ma'am.
Yeah. So in this patient, what else would be done?
Upper GI
Anything would be
endoscopy
done.
can be planned, ma'am,
Why
bec- uh,
appropriate endoscopy to be done?
because it can be associated with as it's TIF1 gamma and he has
But
dysphagia,
you have done the
which
PET scan.
actually persisted with, yes, ma'am, it takes time, but it's actually persisting even with treatment. So we actually planned for upper GI endoscopy for this
So
patient.
actually, before, I mean, you can do the swallow assessment rather than upper GSCOP. The
Okay,
swallow
ma'am.
assessment is better for the management, and you can always, try to take help of the physiotherapist to do the swallow assessment. And
Yes,
you should
ma'am.
do the swallow therapy. It is as important as giving the drugs.
Yes,
And
ma'am.
yeah, and the physiotherapy
Yes, ma'am.
has to be
Physiotherapy that
continued.
can be started, rehabilitation can be started a little slowly in the form of passive movements,
Yeah.
uh, as tolerable,
Mm.
as tolerable by the patient, and
Because
any
now
splinting that
it's
we
really
can do
proven that physiotherapy and this plays a very important role in outcome of the individuals. Uh,
to prevent contractures sequely
Contractors
also
and
it can have.
yes, and it is to give some kind of a boost up to the muscle fascicles which are not active. So the
Yes, ma'am.
physiotherapy helps for that. Okay,
Yes, ma'am. We can also splint the joints, neck band, neck collar, or splinting the other joints at the wrist.
okay.
That can prevent contractures, ma'am.
So at the end of 1 month, how many months he has undergone now? Almost
Uh,
five, six
he,
months, right?
Yes, ma'am. He was improving the muscle weakness. The MMT-8 score came to around 80 by 80, but
Yeah.
he stopped taking medication in between, ma'am.
Oh,
Recently, he presented to us with 2 months default of medications, but he didn't have any relapse in the muscle weakness, ma'am. But
hmm.
he's having significant weight loss, ma'am,
Okay.
and dysphagia is persisting.
The
So we're
dysphagia takes
planning.
the longest amongst all this I have seen in TIF gamma. It takes a very long time, and that's why this you will have to give all the things to prevent the aspiration. You will have to give them lot of
Yes, ma'am.
instructions about eating. Otherwise, we better to give the RT feeds other than giving them food because that produces much more problems.
Yes, ma'am.
Yeah, and the secondary infections also in the chest. Uh,
Aspirational. Yes,
yeah,
ma'am.
aspiration. That's very important to be managed. In this such a kind of a patient.
Yes,
Yeah.
ma'am.
Okay. If the patient is not responding, what are the other therapies you can try?
In case the patient is not responding, the other therapies that we can try is cyclophosphamide, rituximab.
Why
Uh,
cyclophosphamide? That would be for the ILD. He doesn't have it,
yes,
no?
ma'am. ILD part.
Yeah,
Yes,
yeah,
ma'am.
yeah. Okay. What about
Uh,
IVIG?
IVIG, ma'am. Yes,
Yeah.
it can have a rapid onset of action, and it can also be used in patients having infections, ma'am.
Yeah. Are there any trials of small dose of IVIG given periodically?
I'm not aware of the trial names, ma'am, but what is suggested is we can give IVIG monthly for
Yeah.
3 to 6 months.
Correct. So monthly, and we look before that also you can boost up the patient with rituximab. So the trials also considers combination of rituximab and IVIG. Otherwise, IVIG can be also given monthly.
As a
What is the
bridging
dose of
therapy, we can
IVIG?
give.
Yeah, bridging therapy, and they show better response. That's what they say, and it would not have the problems of infection.
Yes, ma'am.
Yeah. Okay.
The dose is 2 gram per day, ma'am, for
Yeah.
2 days.
2 days or 3 days, whatever. Okay.
Yes, ma'am.
Fine. If the patient comes to you with the acute onset and the CPK is extremely high,
Yes, ma'am.
in any
So
other, what
acute
are the
onset,
conditions where CPK can be very high?
uh, acute onset and CPK very high. First, we'll have to think about rhabdomyolysis, ma'am.
Correct. Correct.
So
What
in
about
this patient, we have
statins?
asked
Yeah.
high colored urine and decreased urine output. We have asked, and creatinine is also normal in this
Yes.
patient.
They are because of myoglobinuria.
Yes, ma'am. Yes.
Yeah. What about statins? What role do statins play in muscle disorder?
Statins can present with simple muscle pain, ma'am, or self-limiting myopathy, or they can present with immune-mediated necrotizing myositis, or they can also
Yes.
rhabdomyolysis can also be there in statins, ma'am.
Yeah. Yeah. And they usually could be refractory to the steroids, right?
Yes, ma'am.
Okay.
Immune-mediated necrotizing myopathy is usually refractory to treatment, ma'am.
Okay. What is the role of muscle biopsy in the diagnosis of this polymyositis or dermatomyositis? Is there any difference, and how do you differentiate?
Yes, ma'am. Muscle biopsy, it can help us to identify clearly what uh, subclass, I mean, what type of myositis is there.
Hmm.
It can help us in prognosis also
Yes.
to prognosticate
Yeah. So in
the.
dermatomyositis, what is the classic feature on pathology?
It has perimycial and perivascular
Vascular.
infiltrates
Yeah.
with CD4 positive T cells, ma'am, and plasmacytoid dendritic cells, and
Yeah.
it also has perifascicular atrophy.
Correct. Very good. That is correct. Perivascular atrophy. And in case of polymyositis, you don't get these features, right?
Yes, ma'am. Polymyositis. Uh, it is usually CD8
It is
positive T cells also.
positive cells, right? Okay. Are there any new drugs which have been tried in polymyositis?
JAK inhibitors are the current.
Correct. They are
Uh,
used also in cases of calcinosis.
yes,
Jacket.
ma'am.
Yeah. Okay. Any
Yes,
any
ma'am.
other new drug? Anti-interferon?
Uh, Anti-interferon alpha is tried.
Yeah. Yeah. So the trials are going on. It's not
Yes,
yet.
ma'am, because it has high interferon one
Yeah.
signature.
Yes. That is why this has come.
Yes, ma'am. Even anti-TNF are also being tried.
Okay. So this patient's ANA is positive, and what about the blot?
We had not done any blot because of the financial constraints, ma'am. Only myositis panel was done. In that, any overlap antibodies are not there, ma'am. This covered some of the,
PL70 was also negative, but TIF1 only has come positive. Yeah.
and row 52
Row
is weak
52
positive.
also. Yeah. Okay. Okay. What is the significance of these other antibodies like anti-synthetase antibody, and can you just name this PL712
Yes,
EJOJ? Yeah.
yes, ma'am. Most common anti-synthetase antibody is
Yeah.
Jovan, ma'am.
Yeah.
The other are PL7, PL17,
So how far
Ha.
these antibodies are specific, or they are helping you for the treatment?
Anti-synthetase treatment is usually syndrome is usually associated with ILD, ma'am.
Yeah.
So maybe we'll have to monitor if there's any underlying ILD,
Yeah.
and we'll have to give treatment specific for ILD like cyclophosphamide and
Okay. So they are
rituximab,
mainly
MMF.
associated with the rapid this thing,
Progression of
NSAID pattern, right? And what about
MDA5
MDA5?
usually
Yeah.
MDA5 usually has the rapidly progressive ILD,
Progressive
ma'am.
ILDs, correct. NXP2 is associated with,
NXP2 is usually associated with the calcinosis in juvenile part, and is also associated with malignancies, ma'am.
yeah, it can be
Um,
associated with the malignancy and cutaneous manifestation sometimes.
yes,
In
ma'am. Both
juvenile,
cutaneous manifestations. Yes, ma'am.
yes. Okay.
Dr.
MI2
Amit?
not so very bad.
MI2 is a typical dermatomyositis. It gives a clinical picture of the typical dermatomyositis, ma'am. It has a good
Good
prognosis
prognosis.
also.
Yeah. So this gives you prognosis as well as sub-classification of various
Subclassification.
disorders, and you can make out which patients will go where, right?
Yes,
Yeah.
ma'am.
Okay. Sorry. If any
Dr.
other
Amit?
question?
Dr. Amit, you can
Yeah,
answer.
sorry,
Yeah.
there was a network failure, so I
Yeah.
got
So
logged
I
out.
was just carrying
Yeah,
on. I'm trying to correlate with you.
yeah, Dr. Nikhila, just want to ask two, three questions. Uh,
Yes, sir.
what, uh, what is the significance of anti-synthetase? Which antibodies correlate with that?
I think she has
Anti
answered already.
Okay, it's covered.
Yeah.
So,
HOPs.
yeah, necrotizing myopathy question was asked, so she answered, I guess.
Yes.
Okay. So what influences the your drug of like which immunosuppression to be chosen? Which in factors influence that? Can you tell me briefly?
Severity and extramuscular organ involvement can influence the treatment parts, sir. Uh, Usually, Folitrax is the first line of choice to be started as an immunosuppressive
Mhm.
agent. And
Generally,
if
So,
there is any
problem
lung
with
involvement,
methotrexate,
if
any
there's any lung involvement, we can also give try MMF,
yeah, the
or we
one is
can
lung
try.
involvement and the other one is increase in the SGPT. Sometimes when you don't know whether it's because of methotrexate or it is because of the
Yes,
disease.
ma'am.
yeah.
Yes, ma'am. In that case, we can rely on gamma glutamyl transferase for the toxicity of methotrexate.
Yeah.
So one spectrum of the ILD in dermatomyositis is called as RP-ILD, which is rapidly progressive
Rapidly
ILD.
progressive. She said
So
that.
E-
what is the physiological marker of that?
Anti-MDA5.
Yeah, cool,
Yeah.
great.
And mechanic hands and anti-MDA5.
Yes,
Yeah.
yes, ma'am.
Are there any other drugs which are given for calcinosis, which is very refractory in the treatment?
Sodium thiosulfate, we've tried recently for one patient, ma'am, injectable.
Warfarin is used.
Intra
Warfarin trials are also there. Calcium channel blockers are there.
Nifedipine, yes, ma'am. Calcium channel blockers.
Yeah, yeah. And recently, I think JAK inhibitors also have been tried.
Oh, yes, ma'am.
Okay, I think Dr. Pathak, we
Yeah,
can
Dr.
wind up.
Amit.
Yes,
Yeah, because we are otherwise we'll run short time.
yes,
Short
yes.
time. Yeah. Thank you, Nikhila. It was a
Uh,
very good
thank
presentation. Very nice.
Thank you, ma'am. Thank you so much,
Yeah,
ma'am.
thank you. Take care.
You can give some feedback or what else you should read, Dr. Jyotsna, Dr. Amey.
Yeah, sure.
I
No,
feel
one small suggestion is, in these, whenever I've been an examiner or otherwise, they are very, what you said, they are really biased only on rheumatological conditions. In the beginning of deciding the differential diagnosis, you should be as broad as possible.
Yes, ma'am.
Yeah, yeah.
Yeah, indeed, ma'am has given a very useful suggestion as such. So at the end of the your HOP or history of present illness, our job is to keep as many differential as possible, and
Yes.
uh, at the end of the negative history, we short. I mean, we can decrease the number of differentials,
Yes.
and which goes
Oh,
down further at the end of examination.
Yeah.
Uh,
yes.
so on the same point, I would like to tell you to read more about CTD-associated myositis and the causes behind it also, which are great mimickers of the inflammatory myopathies.
Correct.
So why the muscle involvement is occurring in scleroderma per se? It would be as many causes like overlap of scleroderma with myositis or scleromyopathy, which is much commoner
Yes.
than scleroderma myositis.
Yes,
Similarly,
sir.
Sjogren's also, the cause of muscle weakness can be variable from the periodic paralysis or to the myositis, which is more rare one, but still a differential in case of
Yeah.
Sjogren.
As you keep on seeing
Yes.
cases, you
Uh,
realize so many other
yes, ma'am.
diseases have myositis
We
as a feature, like scleroderma, Sjogren's, and lupus also.
Yes, ma'am. Recently, we had a case of hypokalemic periodic paralysis.
Yeah.
Initially, we thought that to be myositis, inflammatory myositis, ma'am.
Yeah. Remember, one other thing is that in case of myositis or inflammation, the power is never less than 4, It should be 4, 4 minus. If you get really a paralyzed patient, then you always think of something else.
Yes, ma'am.
Okay, they are not completely paralyzed in that sense, but bulbar muscle weakness can come. That can be
Yes,
very
ma'am.
bad. Yeah. Okay.
Okay. I
Thank
Yes,
you.
ma'am.
think,
Thank you, ma'am.
yeah, I think that's an excellent discussion. And we've got a lot of students who have attended and they've got a lot of good questions and good answers. Thank you, Dr. Jyotsna ma'am. Thank you, Dr. Amey Pathak. And Dr. Nikhila, that was a nice presentation. You can stop sharing your screen.
Yes, ma'am.
Okay, so we
Thank
will
you.
go on to the next session. Dr. Shrinivas, you're there?
Hello.
Hi, Dr. Shrinivas, you're there?
Yeah, I'm right there,
Yeah.
ma'am. Good morning.
Good morning, good morning. Mr. Prasad, can you start sharing your slides?
Sure, yes, ma'am.
Yeah, so I'll just introduce you. So today we have, after a very good case presentation, we have a little unusual topic for today, but it's a very relevant topic in today's context. The oncology and rheumatology interface is a very important one. And recently, many of the chemotherapeutic drugs that we use, the new ones are coming, it's difficult to keep pace with all. But one thing that we noticed is the immune checkpoint inhibitors. And Dr. Shrinivas and I, we had certain common cases, where they gave immune checkpoint inhibitors and they had some rheumatic illnesses subsequently. So let me welcome, it takes me great pleasure to welcome Dr. Shrinivas Kulkarni on behalf of Maharashtra
Hello.
Rheumatology Association. We have this session once a month where we have a case presentation followed by guest lecture. So it's a pleasure to have you as guest faculty today. Dr. Shrinivas Kulkarni is a renowned oncologist in Pune city. He's attached to the Shri Sayadri group of hospitals. He's an alumni. He did his DRNB from Manipal group of hospitals where he trained in oncology. And after that, he's been practicing with Sayadri group of hospitals. And he's an excellent teacher, very meticulous physician, very meticulous in his notes. I keep telling my students that you should see his notes that he puts, in the files. Very, very meticulous and neat and very methodical. So I welcome you, Dr. Shrinivas, and hand over to you for your talk on immune checkpoint inhibitors, oncology and rheumatology interface. Over to you.
Sure, ma'am. How much time do I have, ma'am?
You can speak for 45 minutes.
Sure,
And you can keep
sure,
some 5 minutes for question answers.
sure.
Questions can be put in the chat box also by all the students and attending faculty. So we'll
Yes,
take them at the end of your talk. Yeah.
Yes.
Over
Yes.
to you.
So I'm just joining through my mobile, so I'll just make my video switch off actually, and
Yeah,
we'll
yeah,
just continue with the audio for a better
yeah.
range coverage.
Yeah,
Okay.
you can tell next slide and Mr. Prasad will operate it. Huh? Yeah.
Sure, ma'am. Sure, sure,
Oh,
sure.
okay.
Okay. Good morning, one and all. First of all, at the outset, I would like to thank Maharashtra Rheumatology Association, especially Dr. Kavita Krishna Madam, for the invitation and giving me an opportunity to talk on such a topic, which is actually a learning curve for both the specialities, actually rheumatology as well as oncology, and that's immune checkpoint inhibitors, oncology and rheumatology interface. Next slide, please. So I will start my talk by the introduction of these two gentlemen. On the extreme left is Tasuko Honjo from Japan, and in the middle is James P. Allison from United States. These both gentlemen actually won Nobel Prize in the subject of medicine in 2018 for their contribution in discovering, understanding the mechanism of immune checkpoint inhibitors or immunotherapy, that the body's immune system can be harnessed to attack the cancer cells. And since its inception in 2015, it has changed the treatment of many advanced cancers, including lung cancer, renal cancer, bladder cancer, melanoma, head and neck cancer, and the list is ever increasing. So we should thank these two gentlemen, Tasuko Honjo and James P. Allison, for their contribution in the field of immunotherapy in managing cancer patients. Next slide, please. Next slide. So what is immunotherapy or immune checkpoint inhibitor? I'll be pronouncing it as ICI henceforth. And how does it work? To understand that, next slide, please. Let's understand the immune system of the body. We all are aware that immune system of the body has two components, that is innate immunity and adaptive immunity. Innate immunity are the rapid responses that we get to see from the body, and adaptive immunity are the slow responses that we get to see from the body. So the slow response, that is adaptive immunity, has two components, T cells and B cells. In T cells we have again CD4 plus cells, CD8 plus cells. If we see the innate immunity or the rapid response components, we have granulocytes, mast cells, dendritic cells, macrophages, natural killer cells. This slide was just a revision to understand the various components of the immune system and the types of immunities that our body has. Next slide, please. So, what is cancer immunity? Cancer immunity is also called as immune surveillance, and it is a process by which the immune system targets the cancer cells and kills it. Let's understand this diagram. We will start from a clockwise direction from 8 o'clock position. We have a step 1 there, which has release of cancer cell antigens into the circulation once the cancer cells die. These release of antigens, often termed as neoantigen, which are actually presented to the body's immune system. They are actually presented to the dendritic cells and antigen presenting cells. It results into the activation, initiation, and propagation of anti-cancer immunity, resulting into priming and activation of these APCs and T cells. Step 4 is actually trafficking of T cells to tumors. These are called as tumor infiltrating lymphocytes. Step 5 is nothing but the further infiltration of the T cells into the tumors. And step 6 is actually recognition of the cancer cells by the T cells and specifically targeting them and killing them, resulting into something called as immune surveillance. We all know that our body has immune system and we have in our body something called as tumor suppressor genes. Then why only some of the subjects or some of the patients only develop cancers? We need to understand that. See, cancer cells are very smart cells. They keep themselves hidden from the immune system of the body. What does immunotherapy does is makes these cancer cell recognized by our immune system as foreign and specifically target them. So we need to understand the basic concept of immunotherapies or immune checkpoint inhibitors. it actually causes the augmentation of immune system of the body. So there are two ways of immune augmentation of the body. One is actually pressing the accelerators, and second is actually releasing the brakes. So if we see the data of pressing the accelerator, it causes uncontrolled stimulation of immune system of the body, resulting into severe toxicities. So then the concept came of releasing the brakes from the immune system and identifying these cancer cells as foreign and specifically target them. Next slide, please. So these checkpoint inhibitors cause release of the brakes, resulting into augmentation of the immune system. Next slide, please. So we need to understand this figure, and once you understand this figure, the entire mechanism of action of immunotherapy will be understood. So we have two types of cells. One are T cells, which are present in the body, and second are the tumor cells. Our T cells, which are present in the body, have receptors which are called as PD-1 receptor, which stands for programmed death 1 receptors. And PDL1 receptors, which are present on the tumor cells, actually stands for programmed death ligand 1. So when this PD1 and PDL1 binds to each other, it causes inhibiting T cell responses. And that is the reason why our T cells are not able to recognize these tumor cells as foreign and specifically target them and kill them. What this PD1 or PDL1 blockade does is it basically attaches to the PD1 receptors which are present in the T cells, and it prevents the binding of the PDL1 receptors which are present on the tumor cells with the PD1 receptors. It causes inhibition of inhibitory signals to the PD1, and specifically target these tumor cells with the help of T cell immune augmentation. I hope you are getting the points. I'm just trying to simplify as much as possible. Next slide, please. So in terms of medication, so where are we right now in terms of immune checkpoint inhibitors? So there are three main classes of immune checkpoint inhibitors. The first class is actually anti-CTLA4 antibodies. Second class is actually PD-1 inhibitors. Third class is PDL1 inhibitors. In anti-CTLA4 antibodies, we have two medications available which are called as ipilimumab and tremelimumab. In PD-1 inhibitor class, we have two medications available, and these are nivolumab and pembrolizumab. And in the third group, we have PDL1 inhibitors. These are atezolizumab, durvalumab, and avelumab. Next slide, please. Next
Mr.
slide.
Prasad, the next slide.
Yes. So coming to this slide, it depicts us the durability of responses, the true combat of immuno-oncology. We all know that when we use chemotherapy in cancer patients, we get a lot of toxicities, and these toxicities are actually transient. The effects are also transient. So we often call these chemotherapeutic drugs at hit and run drugs. But when we see the immunotherapeutic responses, these are actually sustained responses. They are long lasting responses. So whenever we see such kind of curves, what is more important for us to understand tail of the curve. If we see this graph, the red graph actually depicts the chemotherapy or TKI effect, and we can clearly see as long as these are going on, the effect lasts. But if we see the immunotherapy either as monotherapy or immunotherapy combination, we can see the tail of the curve that is becoming plateau or it is flattening. It simply means even if you stop immunotherapy after certain duration, say for example a year, once your immune system is stimulated, the responses are actually ongoing and long lasting. So this is the beauty of immunotherapy, that the tail of the curve remains plateaued or it remains flattened even if you stop immunotherapy after certain duration of time. Next slide. So what are the clinical applications of immunotherapy that we are using nowadays in oncology? And as I told you earlier also, this list is actually ever increasing. We can see melanomas, RCCs, lung cancer, urinary bladder, head and neck cancer, cancers with MMR deficiency, hepatocellular carcinomas, gastric carcinomas, cervical, endometrial, Hodgkin's lymphoma, and still adding more and more indications every day. Why I'm emphasizing on all these things? Because immunotherapy is going to be a future actually in oncology. And yes, technology comes with a cost, innovation comes with a cost. And here, when using immunotherapy, the cost that we need to understand is a cost of toxicity. I'm not talking about financial burden, I'm talking about clinical toxicities or side effect profiles. Next slide, please. Does immunotherapy work in all patients? Not at all. Immunotherapy doesn't work in all patients. So there are certain markers for immunotherapy response assessments, and these are actually PDL1 expression, MMR deficiency, that is by IHC assay, or MSI high tumors by PCR or NGS assays, and tumor mutational burden. So before qualifying any patient eligible for immunotherapy, we end up in testing these three tests on the tumor tissue blocks so that to understand whether the patient is either PDL1 positive or MMR deficient or high tumor mutational burdens, which are the indications of using immunotherapy in particular subset of patients. Next slide. Yes, as I told you, some patients respond, some don't. No good biomarker to predict who would respond. Immune-related adverse events can occur in few patients. In few patients need to be aware of this. So immune-related adverse events are actually very important to understand, because eventually all the things are going to revolve around the management of immune-related adverse events. Next slide. Next slide. So coming to the immune-related adverse events, the adverse events are due to the activation of immune system against the own body cells. Adverse events can occur in any organ. Adverse events can occur more often in skin, thyroid gland, colon, lung, and liver. Immune-mediated adverse reactions can be serious and potentially fatal, but luckily they are not very common. Immune-mediated adverse reactions may be unfamiliar to clinicians. As I told you in the beginning, as we are using more and more immune checkpoint inhibitors, this is basically a learning curve for the oncologists, and it is going to be even a learning curve for the rheumatologists, especially once they are involved in the patient care. Next slide, please. Next slide. So as I told you that it causes stimulation of immune system of the body. So immune related adverse events can impact any organ of the body, right from your endocrine gland such as pituitary gland causing hypophysitis, uveitis or orbital inflammation, lung affection resulting into pneumonitis, adrenal insufficiencies, colitis, arthralgias, rashes and vitiligo, pancreatitis, hepatitis, hypothyroidism, dry mouth, or Zika syndrome like symptoms that I'm going to touch upon in subsequent slides. Next slide, please. Next slide. So what is the timing of these adverse events? In general, immune-related adverse events can occur quite early, mostly within weeks to 3 months, rarely can happen even after 1 year. And this graph actually clearly tells us what are the time of onsets of various toxicities. Rash and pruritus occurs the earliest. Second is diarrhea and colitis. Then occurs basically the
Dr.
hypophysitis.
Srinivas, the
Then
slide is
occurs basically
different.
liver toxicity.
1 minute.
Hello, the previous slide.
Srinivas, this previous slide, yeah. Mr. Prasad, yeah. Now you can start this talk. Yeah.
Yeah.
Now
So,
the graph is
so
visible.
basically, yes. So basically, the immune-related adverse events rarely can happen even after a year. So if we see this graph, it tells us about the timing of onset of immune-related adverse events, and the earliest to occur are commonly dermatological toxicities such as rash and pruritus. Second most common or second to occur are related to gastrointestinal tract. It is colitis and diarrhea. third one is hypophysitis, and the fourth one, that is liver toxicity or hepatitis. Next slide, please. Now, coming to the EULAR guidelines, that is European League Against Rheumatism. So basically, the diagnosis and management of rheumatic immune-related adverse events due to cancer immunotherapy with ICIs. The rheumatic and musculoskeletal immune-related adverse events occur in 10% of the patients with cancer receiving ICIs. Recent emergence of these events, lack of guidelines for rheumatologists addressing them. So Euler task force was established to address the toxicities and the management of these immune related adverse events, and it was convened to harmonize the expert opinion regarding their identification and management. Early referral and facilitated access to the rheumatologist is recommended to document the target organ inflammation. Next slide. Next slide. So what are the challenges on the part of rheumatologists? Wide
To the
spectrum of
previous slide. 1 minute, Mr.
previous
Prasad.
slide. Previous.
Previous. Yeah, yeah. Now keep it. Yeah.
One side, correct. So basically, wide spectrum of musculoskeletal adverse events not fulfilling the usual classification criteria of rheumatic diseases and their differential diagnosis. This is going to be a huge challenge for the rheumatologists. As per the recent survey, larger proportion of rheumatologists have limited experience and a little confidence in managing rheumatic immune-related adverse events, highlighting the need for education and recommendations in this emerging condition. As I told you, it's even a learning curve for medical oncology. So there should be shared decisions or interdisciplinary approach between the patients, oncologists, and the rheumatologists. Next slide, please. What is the simplest mechanism of immune-related adverse events? T cell activation induced by ICIs promotes the inflammatory or autoimmune-like side effects known as immune-related adverse events. This spectrum of toxicities is unique, can affect any organ system. Prevalence ranges from 1.5% to 22%. In one of the study, as stated in the last slide, it ranges somewhere around 10%. And these figures denote that rheumatic immune-related adverse events are underreported. Next slide. So the analysis of phase 3 clinical trials revealed that arthralgia, arthritis, myalgia, myositis, dry mouth, musculoskeletal, and back pain reported in patients receiving immune checkpoint inhibitors. The bottom line is rheumatology should engage with oncologists. I would say the other way. What is more important is that oncologists should engage with the rheumatologists to take their expert opinion to contribute to the interdisciplinary care of patients presenting with musculoskeletal signs and symptoms. Next slide. So while managing these immune-related adverse events, 3 treatment strategies are recommended. Local or systemic glucocorticoids if symptoms are not controlled by symptomatic treatment, and then tapered to the lowest efficient dose. Conventional synthetic disease-modifying anti-rheumatic drugs in case of inadequate response to the glucocorticoids or steroid sparing, and biological DMARDs for severe or refractory immune-related adverse events. Next slide, please. So the basic principles are, since autoantibodies are not found in majority of the patients experiencing checkpoint inhibitor induced rheumatic and systemic diseases, there is no indication to test every patient at baseline. Detection of autoantibodies in an asymptomatic patient would not preclude the start of immune checkpoint inhibitors. And in contrast to other IRAs, rheumatic IRAs frequently persist over a period of time. Specifically, inflammatory arthritis was persistent in almost 50% of the patients at a time of follow-up, with a median of 9 months in a recent study that was published. Next slide. Now, This slide actually, it combines both, because since the rheumatic and the cancer disease both have high impact on the patient's life, even when independently considered and when the disease activity is controlled, we can see that fatigue, pain, functional impairments, emotional problems, or secondary effects of the treatment can also be from oncology side as well as from rheumatology side. The value of an interdisciplinary collaboration between rheumatologists and oncologists is worthwhile. Next slide. Now, these are the principles actually. When we combine oncology and rheumatology interface, we have to take into consideration 10 principles that I'm going to, suggest you. The first principle that tells us is that rheumatology should be aware of the wide spectrum of clinical presentations of rheumatic and or systemic immune related adverse events that often do not fulfill the traditional classification criteria of rheumatic and musculoskeletal disease. When I say so, what does that mean? That we have already seen that the patient may present with arthralgia, myalgia, which are the most commonly reported IRAs. Patient may have polymyalgia rheumatica like syndromes. Patient may also have polyarthritis, not only poly, they may present with oligoarthritis or monoarthritis. More importantly, we need to understand that autoantibodies are often absent. Now, several cases of myositis have also been reported when we are actually dealing with such kind of situation. And we all know that myositis at times can be potentially life-threatening. So the task force have decided to formulate a dedicated recommendation on myositis. Among the various systemic manifestations such as Zika syndrome, dry mouth, more common in males though, CPI-associated Zika syndromes are frequent non-specific autoimmune manifestations of ICIs. The diagnosis is usually suspected through the imaging when the patient presents like sarcoid-like reactions. Patients may present like lupus-like cutaneous reaction. This ICI actually involve all vessel-sized vasculitis, large vessels, medium vessels, and small vessels. Recently, it was also found that the patients experiencing rapid bone loss with checkpoint inhibitors leading to the multiple fractures that were also reported, actually raising the question of a potential influence of immune activation on the bone metabolism. So once we are aware that these can be wide spectrum of presentation with immune related adverse events, we can approach, or we can direct our approach towards the patient evaluation accordingly. Next slide, please.
Mr. Prasad, next slide. Mr. Prasad, next slide, please. I think you can just continue. I don't know. Mr. Prasad, you're there? Oh.
Okay.
Just
Fine.
continue. There's some problem. He'll come back. Yeah.
Okay. Right. So now coming to the second principle, oncology should be encouraged to consult the rheumatologist promptly for the assessment when rheumatic musculoskeletal and systemic signs and symptoms are suspected due to immunotherapy, and rheumatology should provide facilitated access for such patients. Just go ahead.
Further.
So this is why this is important, that oncology should be encouraged to consult rheumatologists as early as possible, because the data that are available regarding the process of referral to rheumatologists suggests that this is not widely done and might lead to delay in the diagnosis. Second, go ahead.
Yeah, further. Yeah, just
This one.
stop.
Yes, right. Second one.
Previous slide. Yeah, but stop.
Yes,
Yeah.
correct. So the oncologists do not approach the rheumatologist early, and it results into the delay in the diagnosis. So the rheumatic side effects of checkpoint inhibitor appears to be underappreciated, which probably delays the proper assessment and treatment. So as mentioned in the overarching principles, a prompt rheumatological evaluation should support the rapid treatment decisions to relieve the patient's symptoms. So currently, that's it. You stop it. Don't change the slides unless I tell you. Okay. Yeah. So if we see the immune-related adverse events, the algorithms for IRAE managements are actually based on the severity and the grade of IRAEs, and commonly used criteria are called as CTCAE criteria version 5. It stands for Common Terminology Criteria for Adverse Events. But while CTCAE grading is routine for the oncologists, the requirement for clinical trial, rheumatologists are less familiar with this grading, which do not accurately reflect the spectrum or the severity of rheumatic or the systemic manifestation. So the task force has decided not to use CTCAE grading system to prioritize the referral, but instead to recommend prompt assessment ideally before starting the glucocorticoids. And for this purpose, rheumatologists should be encouraged to offer facilitated access, since they may be able to avoid systemic glucocorticoids or use lower dose than oncologists to manage rheumatic toxicities. Next slide, please. Now, this is very important to understand. Metastasis and paraneoplastic syndromes and unrelated rheumatic diseases should be considered as a potential differential diagnosis in the rheumatic immune-related adverse events. The comprehensive assessment should be focused on documenting evidence of target organ inflammation based on the history, clinical features, laboratory tests, and imaging and/or biopsy. Now, the diagnosis of immune-related adverse events versus metastasis may become even more challenging as non-malignant resorptive lesions have recently been described, which can mimic the metastasis. Say, for example, pulmonary sarcoidosis-like lesions may also be the first considered as tumor progression, keeping in view the possibility of metastasis. Now, current literature covers the mainly paraneoplastic neurological symptoms with few published data regarding paraneoplastic rheumatic syndrome. So the task force members have decided, the group agreed to include paraneoplastic syndromes in the differential diagnosis of rheumatic immune-related adverse events. Now, there is something called as unrelated rheumatic diseases, and basically, the patient may present with some shoulder tendinitis or lateral epicondylitis or non-inflammatory back pain or complex regional pain syndrome, which may be labeled as immune-related adverse events. So we all need to take these things into consideration. So eventually the task force, EULAR task force agrees that it may be difficult to establish when specific rheumatic feature can be considered related or unrelated. So using the adverse drug reaction probability scores such as Naranjo score scale may help to assess the causal link between CPI and toxicities. Next slide, please. Now, coming to the next principle, that is, in case of inefficacy of symptomatic treatment and depending on the disease severity, local and or systemic glucocorticoids should be considered for immune-related rheumatic and systemic symptoms. Dose regimen, route of administration should be decided according to the clinical entity and activity. When improvement is achieved, systemic glucocorticoid should be tapered to the lowest effective dose to control the symptoms. Now, you all know that in the absence of any contraindication, symptomatic treatment, including non-steroidal anti-inflammatory drugs and or analgesic, should be the initial treatment of choice for mild to moderate rheumatic manifestations. Anti-inflammatory effect of these drugs can be expected within several hours to few days. When the disease symptoms actually do not respond to these initial anti-inflammatory drugs or analgesics, then one can consider starting the systemic steroids. If a symptomatic treatment is insufficient and tissue inflammation is still evident, then systemic glucocorticoid should be considered for both immune-related rheumatic and systemic symptoms. So one of the important thing we need to consider is that steroids are actually avoided concurrently with immunotherapies because it is thought that the steroids impair the activation and the killing ability of tumor infiltrating lymphocytes. So because of concerns of glucocorticoids on anti-tumor responses, EULAR task force did not recommend using methylprednisolone pulses or high-dose oral glucocorticoids in the absence of any life-threatening complications or myositis. The objective of reaching a dose of glucocorticoids to 10 mg or less per day of equivalent prednisolone was considered as an acceptable target dose. Next slide, please. So if we see this, conventional synthetic DMARD should be considered in patients with insufficient responses to the acceptable doses of glucocorticoids or requiring glucocorticoid sparing strategies. Now, if we see in case of active rheumatic IRAs requiring dose of glucocorticoids which are actually higher than 10 milligrams per day of prednisolone, which are likely to hamper the immunotherapeutic responses, the conventional synthetic DMARDs should be considered. And we all know that methotrexate, hydroxychloroquine, and sulfasalazine are some of the commonly used DMARDs, actually either alone or in combination. While using sulfasalazine in immune-related adverse events, one should note that higher proportion of hypersensitivity reactions have been reported with sulfasalazine in context of immune checkpoint inhibitor inflammatory arthritis. Now, one case series reported the initiation of hydroxychloroquine even prior to the glucocorticoids, limiting the glucocorticoid exposure. So, the use of these conventional synthetic DMARDs have not been described for the patients with CPI-induced Sika syndrome. So these are some of the points actually to be taken into consideration when we are actually climbing up a ladder of managing immune-related checkpoint inhibitor toxicities. NSAIDs, analgesics, low-dose steroids, then conventional synthetic DMARDs. Next slide, please. Now
Doctor,
comes the next step. Now,
we
hello.
missed you after when you started talking NSAIDs, no?
Correct. So basically, it basically a ladder which starts with NSAIDs and simple analgesics, followed by glucocorticoids, and then conventional synthetic DMARDs come. Now coming to the next step in the ladder, that is uh, for patients experiencing the severe rheumatic and systemic immune-related adverse events or insufficient responses to conventional synthetic DMARDs, biological DMARDs may be considered, with TNF and interleukin 6 inhibitors being the preferred options for inflammatory arthritis. Now, gastroenterologists have already safely and successfully administered infliximab for the patients with severe checkpoint inhibitor-induced colitis who had insufficient responses to the glucocorticoids. So based on this data, TNF inhibitors infliximab prevailing on etanercept and adalimumab have been reported for severe and refractory inflammatory arthritis. So there is one case study which actually documents, which has a future relevance, that when these TNF inhibitors are used along with immune checkpoint inhibitors, they have a synergistic effects. So there are trials that are actually going on preemptive use of TNF alpha inhibitors along with immune checkpoint inhibitors so as to avoid immune related adverse events, and steroid sparing regimens can be formulated. Next slide, please. Now, the decision to hold or continue cancer immunotherapy should be based on the severity of rheumatic immune-related adverse events, the extent of required immunosuppressive regimen, the tumor response and its duration, as well as future oncology treatment plan in a shared decisions with the patient. So we all know that currently the decisions regarding immune checkpoint inhibitors and immunosuppressive regimens vary from institution to institution. It is noteworthy that several studies reported ongoing clinical benefit in patients who discontinue their cancer immunotherapy for IRAs. But well-designed prospective trials will be required to help to clarify the optimal immunosuppressive regimens in this subset of population. Next slide, please. Now, coming to one of the very important complication of immune-related adverse events, and that is actually myositis. It may be a severe condition. Immunotherapy withdrawal needs to be discussed in the presence of life-threatening manifestations such as bulbar symptoms, dysphagia, dysarthria, dysphonia, dyspnea, and myocarditis, high-dose glucocorticoids, IV immunoglobulins, and/or plasma exchange should be considered. Immunotherapy withdrawal is always necessary in these subset of population. So we can clearly see that the myositis actually belongs to a spectrum of potentially fatal toxicities associated with checkpoint inhibitors, and it is frequently associated with myocarditis and or myasthenia gravis. Notably, it generally occurs very early after checkpoint inhibitor initiation. So the proximal weakness, myalgia are the major symptoms which can mimic the polymyalgia rheumatica-like conditions. So therefore, a high awareness for myositis is needed among rheumatologists with the measurement of creatinine kinase, since increased CKs are seen in majority of the patients with myositis. Now, importantly, one should search for the presence of life-threatening manifestations, as I already mentioned, that is dyspnea, palpitations, or even chest pain, which could be an harbingers of underlying myocarditis. So myositis associated autoantibodies are mostly negative in this subset of population, but whenever myositis is actually suspected, discontinuation or at least interruption of immune checkpoint inhibitors in presence of dyspnea, bulbar symptoms, muscle weakness, and myocarditis is absolutely advisable. In such patient population, high dose systemic glucocorticoids are the first line of treatment, usually 1 to 2 milligrams per day per kg per day of prednisone, median doses up to 70 mg per kg. So these are some of the things which are related to the myositis. Next slide, please. Now, this is very important to understand कि if the patient is having pre-existing autoimmune rheumatic or systemic disease, what should be done, whether to use immune checkpoint inhibitors or, but it is said that the pre-existing or autoimmune rheumatic and/or systemic diseases should not preclude the use of cancer immunotherapy. Baseline immunosuppressive regimen should be kept at the lowest possible dose, that is glucocorticoids below 10 mg prednisolone per day. However, many patients may have a flare of underlying condition and or immune related adverse events requiring use of glucocorticoids and disease disease modifying agents. So overall, the patients with pre-existing inflammatory or autoimmune disease largely been excluded from the clinical trials because of worsening of underlying immune related conditions. So overall, the checkpoint inhibition was discontinued in almost 8% of the patients with pre-existing autoimmune disease as per one of the study. In a recent case series of 112 patients with pre-existing autoimmune diseases treated with checkpoint inhibitors, a flare of pre-existing autoimmune disease or another IRAE was reported in 70% of the patients. Thus, the occurrence of flare or immune-related adverse events was frequent but mostly manageable without CPI discontinuation in 79% of the patients. So the task force agreed that checkpoint inhibition therapy in patients with pre-existing autoimmune rheumatic and systemic diseases was not contraindicated, provided that the patient is well informed and closely monitored. No preventive treatment is needed for these patients. Importantly, this remains a shared decision between oncologists, rheumatologists, and the patients, and whether the checkpoint inhibitors will be used in a metastatic or adjuvant setting is a major aspect to be considered. So that's why I told you earlier that there was one thought process, and the trials are actually in the pipeline, that prophylactic TNF inhibition in these patients, along with immune checkpoint inhibition, is a possible synergistic effective strategy so that the emergence of immune related adverse events or worsening of underlying autoimmune condition will be minimal. Next slide, please. Now coming to the last principle of on managing rheumatic complications or the rheumatic sequences of immune checkpoint inhibition is that before initiation of cancer immunotherapy, there is no indication to test every patient for the presence of autoantibodies. In case of unexplained rheumatic musculoskeletal or systemic symptoms, a complete rheumatological assessment should be performed. So in short, Since the autoantibodies are not found in majority of the patients experiencing immune checkpoint inhibition induced rheumatic and systemic diseases, there is no indication to test every patient at the baseline. The detection of autoantibodies in an asymptomatic patient would not preclude the start of immune checkpoint inhibition. However, there is a particular situation of patients with thymoma who develop checkpoint inhibition induced myositis and who will have anti-acetylcholine receptor and anti-striated muscle antibodies detected in the serum obtained prior to the CPI. Accordingly, the myositis may evolve into severe immune-related adverse events. Accordingly, testing for the presence of these antibodies before starting checkpoint inhibition in a patient with thymoma is recommended to identify high risk of myositis. Next slide, please. Now, after the completion of 10 principles, how to keep in mind the wide spectrum of immune related adverse events, stepwise approach in management of these immune related adverse events, what are the strategies to be exploited while managing pre-existing autoimmune conditions, and whether it is advisable to test all the patients in such given situation. Let's come to the real world evidence, and these are a couple of cases actually that me and Kavita madam had combined managed. So here is the first case with a 53 years old postmenopausal lady with no known comorbidities. She was a teacher by profession. She was evaluated for hematuria and she was found to have left renal mass. PET scan was done, which also showed active left renal mass involving lower pole of the kidney along with left supraclavicular lymph node. So the biopsy from the left renal mass was done, which actually was proved to be clear cell renal cell carcinoma, and left supraclavicular lymph node FNAC was also positive for metastasis from the RCC. Next slide, please. So, based on the diagnosis of stage 4 metastatic renal cell carcinoma, she was started on standard of care, that is immune checkpoint inhibition plus tyrosine kinase inhibitor combination, and that was actually nivolumab plus cabozantinib combination. She was continued on the same regimen for 2 months, followed we did a PET scan for the reassessment and it showed partial response. So she was continued on the same protocol, follow PET scan done again after 3 months, showed further response to the treatment administered. So after almost 6 to 7 months of the combination, she was evaluated once for lower urinary tract symptoms. She was found to have urinary tract symptoms with proteinuria. UTI was treated till the urine showed no growth on culture, but there was a persistence of proteinuria. Now it actually rang the alarms for us that why the proteinuria is actually persisting despite of clearance of UTI and the proteinuria was still significant. Next slide, please. So at the same time, patient also started experiencing the intermittent skin rashes, joint pains involving the large and small joints of the body. Considering the possibility of immune-related adverse events, rheumatology team and nephrology team was actually involved into the patient care. Immune checkpoint inhibition and cabozantinib was kept on hold, and a trial of corticosteroids was given. Kidney biopsy was done. Meanwhile, it showed minimal change disease. ANA blot was done, which showed anti-RO52 positivity. ANA by immunofluorescence was positive in a titer of 1:320. P ANCA, C ANCA were negative, SPEP was negative, and there was mild increase in the beta 2 microglobulin. So the further doses of nivolumab were actually withheld. We changed the cabozantinib to another tyrosine kinase inhibitor, that is axitinib, which has relatively proteinuria sparing action. Further clinical course of the patient was actually fluctuating with ups and downs in overall general condition. In due course of the time, after almost 1.5 years to 2 years, she developed disease progression, and a couple of months back actually she succumbed because of sepsis and multi-organ failure, and it was found that the primary source of sepsis was actually lungs and she had bad bilateral pneumonitis with ARDS. So Kavita ma'am, I would like to intervene you and ask your opinion when such patient comes to you. So what are your actually strategies or approaches in the evaluation?
Yeah, this patient was a little difficult, so we kept her on, I think, hydroxychloroquine and a low dose of steroid. And
Yes.
with that, she had very mild Zika symptoms to start with. So we thought she was, like a Sjogren's. And she had also little hypokalemia. So we thought maybe she's going with renal tubular acidosis. So rheumatic wise, I think she was okay with hydroxychloroquine and 5 to 10 milligram of steroid. But I think there were multiple infections, I think, after that.
Right,
So yeah.
right. So while managing these patients, we want to consider immune-related adverse events. Not only that, we should also take into consideration the possibility of unmasking of underlying autoimmune diseases that are actually were undiagnosed and patient was never aware of the clinical condition. Next slide, please. This is another patient. Next slide.
Next slide. Yeah. Now you can continue. Yeah.
Yeah. So now coming to the second case, he was a 72 years old elderly gentleman with comorbidities of hypertension and diabetes. He was diagnosed with metastatic hepatocellular carcinoma. He was started on treatment with immune checkpoint inhibitors. He did reasonably well for almost a year's duration. And again, he was evaluated for non-specific fatigue, bilateral lower limb weakness, clinically, proximal muscle weakness and polyarthralgias were there. Rheumatologist Dr. Kavita Krishna Madam's opinion was taken and was evaluated. Madam, any takes on this patient?
I think this one we gave low. She was like a serum. She had a lot of, though it was ANA positive and anti-CCP rheumatoid factor negative. She had a lot of joint swelling and pain, if I remember. So we gave low dose steroid, and we thought we'll give methotrexate, but it responded to low dose steroid, 5 to 10 milligrams of prednisolone with little NSAIDs, like whatever was hepatosafe. I think we just put her on paracetamol and tramadol tablet. Yeah.
Yes, and even after that, actually, the patient received few more doses of immune checkpoint inhibitors.
Yeah.
But because of some or the other reasons, he could not continue with the same. And then we stopped his immune checkpoint inhibitors and we took him on tyrosine kinase inhibitors. And I think he's pulling on basic or
Yeah.
the low dose of tyrosine kinase inhibitors, mainly in the form of lenvatinib. I
Yeah,
think
he's
that
holding
was
on. Yeah.
yes. I think that was the last slide of my presentation. Thank you so much for the patient listening.
Yeah.
And as I told you right in the beginning, again, I would like to conclude by saying the same thing that this is also a learning curve for all of us. That at the same time, when you think of immune related side effects, we should think of unmasking of underlying undiagnosed autoimmune conditions, and we should ask the rheumatologist's opinion as early as possible, and it should be a interdisciplinary approach with rheumatologists, oncologists, patients, and whatever organ system have been involved, those specialties should also be involved. Thank you so much for the patient listening and opportunity. Thank you so much.
Thank you, Dr. Shrinivas. It was a very lucid and very nice presentation, kept us engaged throughout. So while on one hand, we don't need to check the antibodies prior, at the same time, we could be unmasking certain autoimmune diseases. So vigilance and regular follow-up and high index of suspicion is very important. So there are a couple of questions in the chat box. First one
Yes,
is,
ma'am.
I think you gave some criteria for starting immune checkpoint inhibitors. So do you need all the three criteria to initiate immunotherapy?
No, ma'am, not at all.
Yes, because you
Either
mentioned three, that there was
yes.
somebody.
So
Yeah.
basically, either of three criteria are actually sufficient to qualify any patient for immunotherapy, either PDL1 positivity or MMR deficiency or high tumor mutational burden. We often give a cutoff. When we say tumor mutational burden, we give a cutoff of 10. The tumor mutation more than or equal to 10 per megabase is a cutoff. If it is more than that, it is called as high tumor mutational burden and the patient qualifies for immunotherapy. So high tumor burden, high tumor mutational burden, or PDL1 positivity, or MMR deficiency, or MSI high status are the criteria for immunotherapy.
Anyone is fine, huh? Yeah.
Anyone is fine, ma'am. Anyone is
How,
fine.
next question is how to differentiate paraneoplastic manifestations from ICI-induced adverse events?
So basically, there are no clear-cut or consensus guidelines on that. We have to be clinically vigilant. So whatever paraneoplastic syndrome, and one of the most commonly diagnosed and reported paraneoplastic syndromes are actually neurological. So we have to involve neurospecialties also, and if at all needed, we'll have to do the CSF analysis of these patients and send the CSF sample for the what you can call it as autoimmune panels to find any antibodies are there or no. But eventually it's basically a clinical judgment. Biochemical evaluation and imaging studies will make you reach a diagnosis and differentiate these things from a paraneoplastic syndromes or immune related adverse event, but there are no established guidelines as such.
If a patient develops ICI-related adverse event, gets treated with DMARDs or steroids, as we said, try to give a low dose of steroid and achieves remission, but the cancer is not remitted. So we continue or restart. I think you already mentioned that in such a patient, the immune checkpoint inhibitors, right?
Yes. So one of the point to be taken into consideration is that when we grade the toxicities which are actually immune related, as I mentioned, there are criteria. These are CTCAE criteria version 5, and it grades the severity of these adverse events into grade 1, grade 2, grade 3, grade 4. And once you reach up to grade 2 or less, you can actually restart or re-challenge with the immunotherapeutic agents. Grade 3 and grade 4 immune related adverse events are the indications actually to stop the immune checkpoint inhibition permanently.
I think you mentioned if it's a myositis, muscle weakness,
Yes.
you should stop. Yeah, but that
Because
is more life-threatening.
yes, yes.
How to differentiate ICI-related adverse events like myositis from actual inflammatory myositis or myositis associated with malignancy that can precede muscle weakness, like again paraneoplastic, it can precede by a few months or years.
So, ma'am, again, if you go back to the history and if you see the time of onset of the symptoms and the time of start of the immune checkpoint inhibitors, and that is correlating, we can actually, make a diagnosis whether it is an immune-related adverse event. Eventually, we end up in doing biochemical tests, either creatine kinase are done, or muscle biopsies are done to diagnose these inflammatory myopathies. But as such, one cannot differentiate actually based on these finding whether it is a immune related myositis or it is actually a worsening of the underlying undiagnosed myositis like condition. Eventually the treatment remains the same, but one has to be clinically vigilant and find out the timelines. When was the immune checkpoint inhibitor started, when were the symptoms started, and correlate it accordingly.
So after how much time of immune checkpoint inhibitors do the myositis that is due to that start?
Ma'am,
Like
usually it starts within 1 month or so.
after a month, okay.
Yes, yes.
And in either case, we should not stop the immune checkpoint inhibitor if it's a myositis, right?
But if
IV.
if it is only myositis and it is not associated with any kind of bulbar symptoms like
Okay.
dyspnea, dysphagia, and other thing, we can actually temporarily discontinue the immune checkpoint inhibitors, give some short course of symptomatic treatment, NSAIDs and steroid. Once the patient is symptomatically better, reverts back to grade 3 or less toxicity, we can actually initiate. But association with these bulbar symptoms or dyspnea or dysphonia,
Dysphagia.
speech disturbances, myocarditis or myasthenia gravis, these are actually the red flag signs to stop ICIs for permanently.
And then maybe give them IVIG early.
Absolutely, absolutely.
Other thing I wonder, you said about prophylactically giving anti-TNFs. So, with all these things, the infection rate, is it going too high or, I mean, like,
Ma'am, Ma'am, these actually trials are ongoing and there is no concrete or conclusive evidences or the conclusions that were being drawn from these studies, because it was thought that the TNF alpha inhibitors and immune checkpoint inhibitors can work synergistically that may reduce the extent of IRAs or dependency on steroids. these trials are being in the pipeline, and I think only time will answer the utility of these trials and the utility of TNF inhibitors actually prophylactically in the given clinical context.
Mhm. So I think it will remain always an interface where we need to discuss
Absolutely.
with you all what to do further, and maybe the neurologist also many a times, because as you said, there is no guideline of baseline autoantibody checking. Even afterwards, when they get the symptom, they may be antibody negative. So we need to be vigilant, and maybe we'll get more answers in the coming years. Any more questions by anybody? Yeah, I think we did the check questions in the chat box. Thank you so much, Dr. Shrinivas, for spending time on Sunday. Thank you, everyone, for joining us today. So good day to all of you. Happy weekend, happy Sunday. Bye, everybody. Yeah, bye, Shrinivas. Thank you so much. Yeah,
Thank you so much, ma'am.
yeah.
Bye.
Okay. Thank you. Bye bye. Yeah.